1 in every 2 adults has heard it at least once. You need surgery. And here's the terrifying part. Studies suggest that between 10 and 20% of all operations performed in the United States may be completely unnecessary. For spine surgery alone, over 50% of lumbar procedures have been flagged as unjustified. 2.4 million unnecessary surgeries. That is not a rounding error. That is a system-wide failure. And if you have ever been handed a surgical referral without a second opinion, without a full conservative workup, without anyone asking why, this video is for you. The system profits when you stay on the operating table, not when you walk out healthy. Subscribe to Dr. Ethan Parker and hit like. We are on the way to 1,000 subscribers. And what I am about to tell you is not something a fee-for-service clinic has any financial reason to say out loud. Let me start with the most important principle in all of surgery, one that surgeons know in their bones, but rarely say to patients directly. The best operation is the one that was never performed. That is not cowardice. That is not laziness. That is hard-earned medical wisdom. The moment a scalpel touches your skin, the clock cannot be reversed. Scar tissue, the dense fibrous material your body lays down to seal any wound, does not disappear. It remodels the mechanics of your body. It compresses neighboring structures. It restricts blood flow. It is by definition permanent. That is why every surgeon worth their credentials should be asking one question before booking the OR. Have we truly exhausted every conservative option? Because once you go under the knife, that question has no more answers. Let us talk about the 5 operations I see performed most often without sufficient justification, and what you should be doing instead. The first is spinal disc herniation surgery. You come in with low back pain, you get an MRI, the report says herniation. And within days, a neurosurgeon or a neurologist is telling you that you need an operation. Here is what nobody tells you at that appointment. If you pulled 100 random people off the street and MRI'd their lumbar spines, completely asymptomatic people, no pain, no complaints, roughly 50 of them would show a herniation or disc protrusion. Half the population. Most of them have no idea, which means the image on the scan is not the diagnosis. The image is a finding. The diagnosis requires a patient who is suffering in a way that matches that finding. And even then, surgery is rarely the first answer. When is disc herniation surgery genuinely necessary? There is one situation that qualifies as a true surgical emergency, cauda equina syndrome. That is a condition. Cauda equina is Latin for horse's tail, which describes the bundle of nerve roots at the base of your spinal cord, where compression becomes so severe that you develop progressive leg weakness, loss of bladder or bowel control, or numbness in the groin and inner thighs. That is a genuine emergency. You operate. But this is rare. The overwhelming majority of herniation cases involve chronic low back pain and intermittent sciatica, nerve pain that radiates down the leg, and that responds to conservative management. Here is the physiology. Your spine is a stack of vertebrae, the individual bones, separated by discs. Think of each disc as a thick gel-filled pad that distributes pressure evenly between the bones above and below it. When the loading is symmetric, the disc stays centered. But when your pelvis is rotated, when deep stabilizing muscles are in chronic spasm, when old trauma has shifted the mechanical balance of your skeleton, the pressure becomes asymmetric. The disc gets pushed harder on one side and bulges out the other. That bulge is the herniation. And the crucial question is this: if you surgically remove that bulge, but do nothing about the asymmetric loading that created it, what happens? Your body needs a buffer, so it builds another one at the level above or the level below. Within 2 or 3 years, you are back to imaging a new herniation, often at an adjacent segment. This is not a surgical complication. It is a predictable biomechanical consequence of treating the symptom instead of the cause. The root causes of that mechanical imbalance are varied: hip joint dysfunction, pelvic torsion, a rotation of the pelvic bones out of their neutral alignment, chronic spasm of the deep paraspinal muscles, ligament tension from old injuries, a hard fall on the tailbone years ago, a whiplash injury that was fine according to the X-ray, but left structural asymmetries behind. These old injuries disrupt the balance of load across your lumbar spine, and over years, that asymmetry translates into pain. What I find remarkable in clinical practice is that the duration of symptoms almost does not matter. I have seen patients who have carried low back pain for 10 years, 20 years, 30 years. And when you restore proper pelvic mechanics, release the muscular tension, and correct the biomechanical loading patterns, the pain resolves. Not gradually over months, sometimes within a handful of sessions. 30 years of suffering in the right hands doing the right work can change everything in a matter of weeks. That never stops being extraordinary to me. The research backs this up. Published data from a prospective cohort study comparing surgical and conservative treatment for lumbar disc herniation found that surgery offered faster pain relief at 6 weeks, but at 1 year and 2 years, the outcomes between surgical and conservative groups were statistically comparable. A subsequent meta-analysis confirmed the same pattern. Surgery wins in the short term, but by 24 months, there is no significant difference in pain or function. The reoperation rate after discectomy, surgical removal of the herniated disc material, runs between 8 and 12%. That is 1 in 10 patients back on the table. So before you agree to spinal surgery, do this first. Find a qualified musculoskeletal specialist, someone trained in biomechanics, not just imaging. Work through a full conservative course of treatment that addresses the mechanical cause, not just the pain. Only if you develop progressive neurological deficits, worsening weakness, bowel or bladder changes, does the surgical conversation become truly urgent. The second operation is hemorrhoid surgery. Hemorrhoids are swollen veins in the rectum and anus, essentially varicose veins of the lower digestive tract, and they are extraordinarily common. Surgeons are often quick to operate, especially when there is visible bleeding. And yes, surgery does work. A recent meta-analysis confirmed that surgical treatment achieves higher rates of complete symptom resolution and lower short-term recurrence than conservative measures. But here's what that meta-analysis did not address, and what I want you to think about carefully. I want to tell you about a patient I treated, male, middle-aged, hemorrhoids with active bleeding, visibly pale. The anemia was evident before I even had his labs back. He had already been referred for surgery. He came to me not because he believed there was a non-surgical path, but because the prospect of spending a month flat on his back, out of work, out of his family's daily life, was intolerable. He said, "Do anything you can." What I found on examination was significant visceroptosis. That means the internal abdominal organs had descended lower than their normal anatomical position and were pressing down into the pelvis directly onto the venous plexuses of the rectum. Those were the networks of veins around the lower bowel. Blood could not drain upward against that pressure. It stagnated. The veins engorged and eventually ruptured. He also had an old coccyx injury. When the coccyx, your tailbone, is traumatized, it can block the normal micromotion of the sacrum. The sacrum is the large triangular bone at the base of your spine, and in normal physiology, it performs subtle rhythmic movements that assist venous drainage from the pelvis. Block that motion and you accelerate venous congestion. He also had restriction in the occipital bone, the bone at the base of the skull. Here is an anatomical fact that surprises most people. The occipital bone and the sacrum are mechanically linked through the dura mater, a tough fibrous tube that runs the entire length of the spinal canal, enclosing the brain and spinal cord. This is a rigid mechanical connection. A restriction at the top of the chain limits mobility at the bottom. A skull injury can, through this mechanism, contribute to pelvic venous stasis, pooling of blood in the pelvic veins. We worked through all of these layers, lifted the viscera, restored occipital mobility, freed the sacral motion. The bleeding stopped. Surgery was never needed. I am not telling you that hemorrhoid surgery is never appropriate. That would be false. In advanced disease, surgery is clearly the superior option, and the data says so. But there are cases, and I have seen enough of them to say this with confidence, where the mechanical contributors have never been evaluated. If your surgeon is sending you to the OR without asking about organ descent, without assessing sacral mobility, without understanding the pelvic mechanics, that is an incomplete workup. And even when surgery is ultimately necessary, correcting those upstream mechanical factors beforehand dramatically improves the surgical outcome and reduces the likelihood of recurrence. That distinction matters. This is not instead of surgery, it is before surgery. The third operation is surgical repair of diastasis recti. Diastasis recti is a separation of the two parallel bands of rectus abdominis muscle, the muscles that run vertically down the center of your abdomen, along the linea alba, which is the connective tissue seen between them. It appears most commonly in women after pregnancy and childbirth. The abdomen visibly domes or cones outward when a woman rises from lying down. And when the separation measures 6, 7, 8 centimeters, surgeons frequently recommend operative repair to suture the edges back together. Here is what I have watched happen in practice. Women told they need surgery begin a supervised program of corrective core rehabilitation exercises designed specifically for diastasis. Not crunches which make it worse, but deep stabilization work targeting the transverse abdominis and pelvic floor. Within several weeks, that separation of 7 centimeters is down to 3. Without anesthesia, without a scalpel, without scar tissue, without 6 weeks of post-operative restrictions. Think about that. The surgical indication disappears with exercise. The physiology explains why. Muscle is living tissue. It responds to mechanical stimulus. The right loading pattern, appropriate intra-abdominal pressure management, progressive strengthening of the deep core causes the connective tissue of the linea alba to remodel and the muscles to migrate back toward midline. This is not theory. This is exercise physiology in action. Now consider what surgical repair cannot do. A surgeon can mechanically approximate the edges, bring them closer together with sutures, but that does not restore muscle strength. It does not rebuild the neuromuscular connection, the communication pathway between your nervous system and the muscle fiber. It does not improve coordination. If the muscles remain weak after the repair, the separation can recur. The structure is physically closed, but the function is not restored. For a woman whose body needs to work, carrying, lifting, moving, that distinction is enormous. So if someone tells you your diastasis is large enough to require surgery, pause. Get a referral to a pelvic floor physiotherapist or a rehabilitation specialist with specific diastasis training. Follow the program honestly for 2 to 3 months. The result may save you from an operation entirely. The fourth operation is venous surgery for varicose veins. And this one connects directly to what we just discussed because the mechanism is the same one that drives hemorrhoids, visceroptosis, the descent of abdominal organs into the pelvis. Picture the veins of your legs as a low-pressure return system. Blood climbs back up toward the heart against gravity, pushed along by the calf muscles and a series of one-way valves. Now imagine that the organs of your abdomen, the intestines, the uterus, the bladder, have descended and are pressing down on the major venous vessels of the pelvis. This is exactly like applying a tourniquet at the top of your thigh. Pressure below the compression point rises. The veins distend. The valve leaflets, which are delicate and designed for low-pressure operation, begin to fail. Blood pools. Venous walls stretch. First you see spider veins, those fine red and purple surface capillaries, which are already a signal. Then ropey, bulging varices. The process takes years, sometimes decades. Pregnancy and childbirth accelerate it. Prolonged standing accelerates it. Chronic straining from constipation adds to the pressure. There are also structural factors that weaken the vein wall itself. Vitamin D deficiency impairs vascular smooth muscle function. Inadequate bioflavonoids, the plant compounds found in citrus pith, berries, and dark leafy vegetables, reduce venous wall integrity. Connective tissue dysplasia, an inherited condition where the collagen fibers that form the scaffolding of your blood vessels are inherently more elastic and weaker than normal, means some people's veins dilate faster under the same pressure loads. This is why one woman spends a decade on her feet with no varicosities and her sister develops significant disease after her first pregnancy. Modern vascular surgery offers laser ablation, sclerotherapy, injecting a chemical that scars the vein closed, and mechanical stripping. All of these produce good cosmetic results. The bulging disappears, the leg looks better. But if the visceroptosis driving the venous hypertension, the elevated pressure in the leg veins, has not been corrected, the same pressure gradient rebuilds new varices within 2 to 3 years. I have heard this from patients dozens of times. I've had it done twice, and it came back again. That is not a surgical failure in the technical sense. That is a systemic failure to address the cause. The right approach? Start by correcting the organ descent, relieve the pelvic pressure, address the nutritional deficiencies, strengthen the supporting musculature. At early stages, spider veins, mild dilation, this alone can stop progression entirely. At later stages, When surgery is warranted and the patient wants the vascular work done, restoring pelvic mechanics first means the surgical result lasts. One operation instead of 3. How do you know if organ descent is part of your picture? Stand relaxed in front of a mirror. Look at your abdomen. If it protrudes forward, not because of excess body fat, but in a person who is otherwise lean, that is a sign. A slender woman with a protruding lower abdomen is not carrying extra weight. Her organs have shifted downward. This is not just a cosmetic issue. Pelvic varicosities, leg varices, hemorrhoids, back pain, and even bladder symptoms can all trace part of their origin to this displacement. These systems are not separate problems. They are one anatomy. The 5th operation is surgical repair of pelvic organ prolapse, the surgical lifting and anchoring of a descended uterus, bladder, or rectum. This is a significant procedure, and most women who reach the point of needing it have been ignoring the problem for years, sometimes decades. The mechanism is a two-sided failure. From above, visceroptosis, the abdominal organs pressing downward. From below, a weakened pelvic floor. The muscles of the perineum, the group of muscles that form the base of the pelvis, have been stretched, often by childbirth, sometimes by chronic straining or connective tissue weakness. The ligaments that suspend the pelvic organs have lost tensile strength. The uterus, the posterior wall of the bladder, the anterior wall of the rectum, they begin to slide downward into and eventually toward the vaginal opening. This is not an event. It is a slow, years-long migration. And that gradual nature is simultaneously the danger and the opportunity. The danger, people adapt to slow change. You stop noticing what has shifted until the shift is severe. The opportunity, at early and moderate stages, this condition responds well to conservative intervention. Pelvic floor physiotherapy, targeted rehabilitation of the abdominal wall and perineal musculature, and structural correction of organ position are all evidence-based, effective approaches to preventing progression. I had a patient with first-degree prolapse, meaning the organs had descended but had not yet reached the vaginal opening. We began work, visceral manipulation to reposition the organs, pelvic floor strengthening, anterior abdominal wall rehabilitation. Her symptoms improved substantially. She felt better, and then life took over. She stopped. She came back 5 years later. The prolapse had advanced to the point where conservative management was no longer sufficient. We performed surgery. The outcome was good, but she had missed a window that if she had stayed with the program would likely have kept her off the operating table entirely. I tell that story not as a criticism. I tell it because it is real and because it illustrates what a meaningful thing timing is in medicine. An early-stage prolapse treated seriously is often a manageable mechanical problem. An advanced prolapse ignored is a surgical case. The intervention does not change, but the stage at which you decide to act changes everything. Here is where age becomes genuinely relevant to this conversation. After the age of 50, the connective tissue changes that drive all 5 of these conditions, disc degeneration, venous wall weakening, ligament laxity, facial thinning, accelerate measurably. Estrogen decline in women after menopause is a direct contributor to pelvic floor weakening and increased herniation risk. In men, poor muscle mass diminishes and lumbar loading patterns shift. These are not theoretical risks. They are changes I see on examination every week. So I want to ask you directly, how old are you? Write it in the comments. I want to understand which age groups are watching this, because the practical advice I give a 32-year-old with a new disc herniation is meaningfully different from what I tell a 58-year-old with a multi-level degenerative spine. And knowing your age helps me build the videos that are actually useful to you. Let me bring this together with clear, practical guidance, the kind I would give you in my office. For disc herniation, do not consent to surgery because of an MRI finding alone. Surgery is justified only when you have progressive neurological deficits, worsening weakness, loss of bladder or bowel function, that fail to respond to a genuine, full conservative treatment program. That means months of proper biomechanical rehabilitation, not a few sessions of generic physical therapy. For hemorrhoids, before agreeing to an operation, insist on a thorough mechanical evaluation of your pelvic structures. Is there organ descent? Is there sacral restriction? Has anyone checked your coccyx? These are not exotic questions. They are basic diagnostic steps that should precede any surgical referral. For diastasis recti, a separation measured on imaging is not an automatic surgical indication. Work with a pelvic floor physiotherapist for 2 to 3 months. Measure the gap again. You may find the surgery is simply no longer on the table. For varicose veins, if you are in the early stages, spider veins, mild dilation, no skin changes, address the mechanical contributors first. If surgery is needed later, do it on a body where the cause has been corrected. One procedure done properly that holds. For pelvic organ prolapse, if your gynecologist tells you there is early prolapse, that is not the moment to wait. That is the moment to act aggressively, conservatively, immediately. Pelvic floor therapy and structural rehabilitation at stage 1 can keep you out of the operating room for life. Waiting until stage 3 takes that option away. In every single one of these cases, the keyword is first. First, find the mechanical cause. First, exhaust the conservative options. First, restore the structural foundation. And then, if surgery is truly the only remaining path, go into it prepared. Go in with corrected mechanics, restored tissue quality, and eliminated upstream drivers. Then the surgery is done once, and it holds. I'm Ethan Parker, and I've spent 15 years watching patients agree to operations that their bodies were never the problem for, and watching other patients walk away from surgical tables they never should have been booked onto in the first place. The evidence is clear. Long-term outcomes for conservative and surgical management of many of these conditions converge. Surgery gets you there faster in some cases, but the body, given the right conditions, often gets there too. Give it the chance. Your doctor is not going to walk you through any of this at a 15-minute appointment. There is no billing code for explaining why you do not need a procedure. I am. Subscribe to Dr. Ethan Parker and hit like. We are building toward 1,000 subscribers, one honest conversation at a time. Help make that happen.